Uh, so we said that your title should be tantalizing, your abstract should be amazing, your introduction should be inspiring, your methods should be meticulously done, your results should be rigorous, and your discussion should be deep. The discussion tells us the moral of your story, and the aim for your discussion is to interpret your findings in the light of existing literature. So all that you seek to do is that these are my results. How does my results compare with the existing literature? And have I been able to prove my hypothesis with my work? So you started by saying that these were your objectives. You presented your results. Are your results meeting the objectives that you set out to assess? One of the key things that you must do in your discussion is to interpret your results in the light of your objectives. So I set out to establish that hypertension is a major risk factor for stroke in Africa. And I sought to do this by using a case control methodology where I sought to measure the effect size of hypertension for stroke, association between stroke. I said that I will measure the odds ratio for the association between hypertension and stroke. And the odds ratio that I got from my study was, let's say, 2.5. And the confidence interval for that 2.5, let's say 1.4 to let's say 3.0. So to be able to interpret this, that means I should understand what odds ratio is. So if, for instance, you're saying that the odds ratio is 2.5, it means that you are saying that there's a 150% higher odds of having a stroke when you have hypertension. So you interpret not just the 2.5, but you are now saying that, look, when somebody has hypertension, there's a 150% higher chance of experiencing a stroke than somebody without hypertension. So here you are interpreting your data. Or you're comparing your data with existing data and saying that, well, when I look at literature on stroke in the world, the prevalence of hypertension for stroke in Asia is, let's say, 50%. In Europe is, let's say, 40%. In Africa, the prevalence of hypertension among stroke patients is 90%. Okay, so this brings out a clear contrast in the burden of hypertension among stroke patients in Africa compared to the rest of the world. So it's always important that you address that as soon as possible in your discussion, that, look, this was my objective. My objective has largely been met, and I'm showing that my result findings are consistent with literature, or they are different from the existing literature in this regard. Either I found too low a prevalence compared to what is already published, or too high a prevalence compared to what is published, or my figures were consistent with the prevalence of the existing literature. For instance, one of the recent studies that we did was to report on stroke mortality in Africa using data from Cyrene, Ghana, and Nigeria. And so we said that the 30-day mortality for stroke from our study was, I think, 22% or so. When you compare that figure with, let's say, the data from America and the rest, America is about 10-15% mortality. So we're saying that our mortality rates were higher than the rest of the world. But then we needed to provide explanations as to why our stroke mortality was higher. And so one of the things we tested was, what are the risk factors for stroke mortality in Africa? And what we found was, for instance, aspiration pneumonia was common, was a risk factor for mortality. We also found, for instance, that we had stroke severity at presentation as a risk factor for mortality. We also saw, for instance, that having a raised intracranial pressure at presentation was a risk factor for stroke mortality. These risk factors are not different from what we see in the West. One of the things we thought that we could establish was whether if you had, for instance, a stroke unit at your medical center, whether it's improved stroke mortality. And we didn't find that having a stroke unit significantly reduced stroke mortality, although the literature elsewhere in the world have clearly established that if you have a stroke unit, it reduces mortality. So we have to now discuss why we had this unexpected finding. Why are we saying that in the African context, when you had a stroke unit in your medical facility, it didn't reduce stroke mortality? So we have to balance the discussion that, well, some people have stroke units, but they may not have working protocols. Some people have stroke units, but their medications may not be there to treat acute strokes and so forth. So these are the sort of discussions that you want to have based on the results that you are seeing. So results that tend to agree with existing literature are discussed, that look, this is consistent with literature. Results that don't agree with existing literature has to be discussed. Why is your result different from that which is have been reported? And when you find something new, you want to be able to say that these are novel findings, but you don't want to over-exaggerate by saying that no one else in the world has seen what we are seeing here. Hey, this result, you have to publish it because it's new. You have to sort of be a bit modest without exaggerating. So it means that you should say that, well, these findings are quite characteristic. For instance, one of the things we started seeing when we started publishing our stroke papers was the odds ratio of hypertension for stroke in Africa was 19 point something. Usually, if you read the literature, the odds ratio for hypertension and stroke is, let's say, sometimes 3.5 or 4.5. We found 19 point something. So we said, this is how we couched the report. We said that the odds ratio for hypertension for stroke causation is among the highest reported in literature to the best of our knowledge. So you are presenting something new. You are saying that it's new, but you are being modest about it, that to the best of your knowledge. So if somebody has done something, a study in Turkestan, and you couldn't come across it, and the reviewer knows about it, you can say, but there's a study in Turkestan that says that the odds ratio of hypertension is, let's say, 100. You are saying 90, you are clapping for yourself. So it's always good to sort of be a bit modest and when you are reporting some of these findings without exaggerating. Next slide. Next slide, please. So these are some of the things you should do, precautions you should take when you are discussing your results. Avoid statements that go beyond what the results are saying, and try and avoid unspecific expressions, like saying that, well, higher temperature is associated with this, or there was a low rate, or we have found a highly significant association between hypertension and then stroke. It's usually better to use quantitative descriptions. Okay, so the temperature of 35 degrees was lower than we expected. The proportions that were having, let's say hypertension was, let's say 0.5% lower or higher than what has been reported with a p-value of this. Sometimes that is more acceptable than, over exaggerating your result. And then sometimes you are talking about risk factors for stroke as the main focus for your paper. Then all of a sudden you start bringing in things like there's no policy for this. Sometimes you shouldn't try and introduce new ideas or new items that are not in your objectives, that are not in your results, and you start talking about them. Try and avoid that, and avoid speculations. Usually, when you found something that is interesting, that's you don't have immediate explanation for, you can say that it is tempting to speculate that this and that may be the reason why you are seeing this. Especially when you've done, let's say, a cross-sectional study, or let's say a case control study. You can't, for instance, in a cross-sectional study or case control study, attribute causation. So you observe, for instance, that in one of our studies, we observed that eating green leafy vegetables is associated with a lower risk of developing a stroke, is associated with a lower risk of mortality after stroke. It's an association. But because of the study design, you can't see that eating green leafy vegetables prevents stroke from happening or prevents mortality, because it was a case control study. And besides, if somebody is acutely down with stroke, you cannot give the person green leafy vegetables to prevent mortality. So you must be careful how you sort of interpret what you're finding and avoid over speculations. Next slide. Next slide. And then after discussing your results, usually you want to have in a discussion an implication session and a limitation session. So what are the implications of the finding? When it's all said and done, what and so what? You found this and so what? So that's the implication session of your discussion. Usually I tend to break down implications into implications for policy, implications for practice, and implication for the patient. So if you find, for instance, that hypertension is such a big risk factor for stroke, at the policy level, what should we do with this information? Education, make drugs available. At the practice level, what should we do? Clinicians should screen patients and advise them on hypertension. When they have hypertension, take their medication. At the patient level, what should the person do? Because sometimes patients also read publications. Okay, it's not, now we have a group of patients that do it. We are seeing some of them in our consulting rooms, but it's a very common practice in the West where even patients even subscribe to the Lancet or the New England Journal. So every week there's something they read, or there's even summaries of whatever you're finding. So at the patient level, what should be the take-home message for the patient? And then there should be a session on limitations. Limitations are important because no single study can answer all questions. So some of the limitations that you want to consider are my results generalizable? If, for instance, I conducted a study in Confanoche, can I say that my results are generalizable across all health service delivery points in Ghana? And the answer often is no. So the results may not be generalizable simply because of where you did the study. And then you also need to be honest about missing data. It is almost always impossible to get all your data points for all your the variables for all your patients. So if there were missing data, you have to be able to find ways of describing how you dealt with missing data. And usually the statistician will say missing at random, missing completely at random. They know how to describe all this, but you should be upfront about it. For instance, one of the studies that we did in Cyrene was, stroke patients almost always come unconscious. And you want to find out, have you smoked before? Have you, how often do you take vegetables? How often do you take meat? And we realized that participants were not able to answer those questions because they were unconscious. So we had to rely on relatives to be able to give us this information. But we had to say that, look, a certain proportion of the responses we got were from relatives. And we think that they were they were valid proxies to be able to give us this. But when we're doing the analysis, we're careful to perform a sensitivity analysis. That's looked at the results that we were able to obtain when the patient themselves gave us a result versus the results that we obtained from the relatives or the proxy, and to see whether there were big differences between the sort of results that we got. So always, if there's a limitation, you want to be able to give an explanation why the limitation is there and what you did about the limitation and how the limitation influences how you are interpreting your results of your findings. Next slide, please. And then you have to have a conclusion, and your conclusion must be compelling. Title tantalizing, abstract amazing, introduction inspiring, methods meticulously done, results rigorous, discussion must be deep, your conclusion must be compelling. Now, this is what the person is taking and putting it into his pocket after reading your paper. Okay, so this session shows how the work advances the field from the present state of knowledge. And so without a clear conclusion session, reviewers find it and readers find it a bit difficult to judge your work and whether it merits publication in their journal. So your conclusions must be really solid. You must hit it in such a way that when the person is reading it, it's juicy, it's nice, it's smiling. Wow, this is an excellent work. So you should provide a clear scientific justification for your work in this session and indicate the uses and extensions of your work if appropriate. So in this work, we identify 5 key risk factors for stroke mortality in Africa: aspiration pneumonia, raised intracranial pressure, high blood pressure at presentation, These risk factors are largely modifiable through the implementation of protocols for screening for aspiration, for screening for swallowing, managing raised intracranial pressure. If these measures are implemented, stroke mortality will reduce. Full stop. Okay, so you have to have that punchline that makes it compelling for the reader. Next slide. The acknowledgement sessions, usually you want to thank the people who have contributed to the manuscript, but who were not authors. You also want to acknowledge those who helped you. Sometimes people might have proofread your work. You want to acknowledge them. Sometimes proofreading doesn't qualify you to become an author automatically. You just wanted the person to just look at it for you. One of the key things that you must do at the acknowledgement session is probably to thank your funders. And for some funding agents, it's a requirement. You must put their name down. The grant they gave you, the grant number must be there in the acknowledgement session. Next. References, someone will talk about it next. Next. And I would like to end here by looking at 10 top tips to improve your likelihood of getting your manuscript published. Number 1, you should organize the manuscript properly. Number 2, you should state the study question and study rationale clearly. Number 3, explain the materials and methods in a systematic manner. Number 4, structure the materials and method sessions and result sessions in a similar manner. Number 5, make the discussions concise. I always tend to recommend that you should do maximum 5 paragraphs in a discussion. So 1 paragraph that describes the results, findings, and how it compares with others. If there are any risk factors that you've identified that are unique, you want to discuss them in that 2nd paragraph. Paragraph number 3 is implications of your work. What should we do with the results that you found? Number 4 is the limitations session. Number 5 is your concise conclusion. Typically, it should be concise, straight to the point. You must always try and explain why your work is important. Avoid overinterpretation of your results. If there are limitations, explain them. If there are unexpected findings, account for them. And then when you've had the opportunity to revise your manuscripts, as much as possible, try and incorporate what the reviewer suggested that you should do. I think I'll end here. Thank you very much.
All right, thank you. I think it's time for break. But if you have a couple of questions, maybe we can try to take 2 questions, Prof, if you don't mind, just in case.
Yes, please.